So my talk is probably the easiest for all of you in the audience because you just need to relax. None of the stuff I'm going to talk about is going to be tested on your cardiology boards. But I hope it may cause you to reflect on some of the interesting patients that you've come across in the past. And so I just want to start with a brief clinical report, case report. 57-year-old man, previously healthy, and came to the clinic, our clinic at Stanford, for newly diagnosed non-ischemic cardiomyopathy. He was found to have severely reduced LVEF, and his family's history is remarkable for multiple sudden cardiac death, AFib, heart failure, hypertension. And then we decided to do a genetic testing, and it shows a pathogenic variant in lamin AC. And so the question is, how do you manage this patient, and how exactly does this mutation cause this family to have multiple sudden cardiac death? And so I'm going to tell you something that we've been working on for the past 15 years, and this is we take advantage of this human-induced pluripotent stem cell platform. This is pioneered by Dr. Shinya Yamanaka, and the process essentially involves taking your blood, isolate your PBMC, we hit it with 4 genes, and then we can then transform your blood cells into iPS cells, which are essentially the same as your embryonic stem cells. And once we generate iPS cells, we can then differentiate your brain cells, heart cells, liver cells, kidney cells, any cell type in your body. And then this allows us to characterize the disease phenotype, identify the molecular targets, and implement precision medicine. And so at Stanford, we have so far generated more than 2,000 patients with the iPS cells, and these 2,000 patients have a different medical history, ethnicity, sex, and also we also use isogenic CRISPR lines. These include, for example, hypertrophic cardiomyopathy, dilated cardiomyopathy, ARVC, long QT, LVNC, pretty much anything you can think of, and also chemotherapy-induced cardiotoxicity and so forth. And we use a PharmGK database to help us understand how human genetics impacts the drug response phenotype. And we're also working with FDA on several projects on drug safety testing. And so, let me just push. Yeah, so this is a typical pipeline. We recruit, again, from diverse patient populations. Their blood cells are then transferred into iPS cells, and then we can then generate these human iPS cell-derived cardiomyocytes, as you can see in the middle panel there. We can also generate these 3D beating cardiac organoids, as well as 3D engineered heart tissues. Now, the important thing to keep in mind is that these cells that we generate are genetically identical to you, to the patient who got the iPS cells. So now you can start thinking, once we're able to generate heart cells so easily, what are some of the potential applications? And for example, potential applications could be used for regenerative medicine, for screening for drug toxicity, and also for quote-unquote clinical trial in the dish, as my title suggests. And so in terms of application for regenerative medicine, this is the study design for a first-year man trial involving human ESL-derived cardiomyocytes using a NOGA catheter, and this is being done at Stanford. I'm the PI, along with my colleague, Dr. Phil Yang, who's a co-PI, and also my co-investigators, Drs. Joe Wu, Elgin Lewis, and Ken Mahaffey. We are enrolling patients with chronic ischemic cardiomyopathy. This would be purely a safety study with the dose escalation of 50 million, 150 million, and also 300 million cells. And so far, we have injected in 6 patients, and I hope to report back a year from now when we complete the study. In terms of application for screening for drugs, showing here is a study on doxorubicin-induced cardiac toxicity, and I think for our next speaker, Dr. Moslehi, he's really the expert on this. But for this study, we recruited 8 breast cancer patients. A year later, some of them had normal cardiac function, while others had doxorubicin-induced cardiomyopathy. And the incidence is, anywhere from 5 to 15 to 20%, depending on how long you follow them, depending on how sensitive your imaging machine is. So here we generated the patient's iPSL-derived cardiomyocytes, exposed them to doxorubicin in vitro. We then studied the cardiomyocyte response to doxorubicin, looking at cellular contractility, calcium cycling, metabolism, gene expression, and so forth. And here we show that if we pick the patients appropriately, their iPSL cardiomyocytes can be used as surrogates to predict which patients are more susceptible to doxorubicin-induced cardiac toxicity. And the third application is using it for a clinical trial in the dish. And the idea here is that we should be able to recruit these patients, generate the differentiated cell types of interest, test which patients respond to the drugs and which patients do not by using the iPSLs as surrogates, and then go back to perform the actual clinical trial on the patients who are positive responders for the drug. And so from an individual person's perspective, that is quote-unquote precision medicine, right? I think there's a lot of different definitions of precision medicine. Wearing a Fitbit or wearing an Apple Watch could be considered precision medicine. Here's another definition of precision medicine. From a population level, you can actually use this to accelerate and drug discovery process and decrease the costs involved in it. And so this trial is actually, this type of approach is actually quite timely because both the Senate and House recently passed the FDA Modernization Act 2.0 in December 2022. The law authorizes the FDA to use alternative testing platforms such as human iPSLs, human cardiac organoids, human engineered tissues, and AI machine learning model. And for some drugs to completely eliminate the requirement for animal testing before going to clinical trials. Now, in addition, the EPA, the Environmental Protection Agency, will completely eliminate all animal testing by 2035. So, and then also in terms of the AI machine learning, I think there's been several talks about it, and I'll just give you the perspective from the drug discovery angle. I think there's going to be significant advances in the future for this particular area. So I've shown a slide here. This is in collaboration with computational scientists at Greenstone. We routinely use these AI machine learning softwares that allows us to analyze the protein structure by in silico modeling. And once we know the protein structure, we can actually screen for 1 billion compounds over 2 weeks. And then, so in case you're wondering here, the cartoon on the right will show 3 drugs that bind to the protein target of interest. And here we can see that the drug in pink actually binds to the protein, whereas the 2 other drugs that do not. And so the drug in pink would be something that we would chase after instead of the other 2 drugs in terms of drug development. So let me go back to the patient I started with in the very beginning. I'm sure some of you have seen these patients in clinic, and the question is, what do you do with this patient right here? And so around 2016, we were referred by our electrophysiology colleagues. It's a large family cohort. Has lamin AC frameshift mutation that leads to early termination. Lamin cardiomyopathy accounts for about 10% of all idiopathic or genetic dilated cardiomyopathy. As you can see here, this family, several of them had AFib, AV block, and 8 of them died from sudden death. And then, so the question is, how does this lamin mutation causes all these problems? And since this is not a basic science crowd, I just want to summarize by saying that we figure out that the mechanism, as the title suggests, is due to abnormal activation of the PDGF signaling pathway in their cardiomyocytes, which then leads to abnormal cellular arrhythmia and also impaired contractility. Now, what's interesting to us is that we also noticed that many of these lamin patients within this family also develop early onset hypertension at age 30s and 40s. So at age 30s and 40s, their blood pressure could be 160s, 170s. So we're scratching our head and see, well, how does this lamin mutation causes the hypertension? And so in this case here, we actually differentiated the iPS cells into vascular endothelial cells so that we could study the hypertension angle. And we compared the differences between the healthy versus the diseased Lamin patients. And then we did a whole bunch of basic functional genetic molecular cellular screening and identify KLF2 as a transcription factor that is depressed in these Lamin patients. So we hypothesized that by activating KLF2, you could probably rescue the vascular phenotype. And then we did a whole panel of drug screening. In this case here, focusing on using FDA drug-approved library. And we found lovastatin can actually be used to activate the KLF2. And then so, the final step would be, well, do we give the lovastatin back to the same patient? And that's exactly what we did. So the Lamin patient came back, and we gave them lovastatin. And we used the EndoPad, which is a machine that can assess flow-mediated dilatation. And so here you can see in the middle panel, patient number 2 started with a poor index of 0.48. Normal index is considered 1.67 and above. And so after 6 months of treatment, his index improved from 0.48 to 1.06. And so this is pretty dramatic, even though we give lovastatin purely for the purpose of the vascular dysfunction, for the hypertension. The patient had normal cholesterol. And so I think this is also one example of what we call a clinical trial in a dish, whereby we first identify a large family with a Lamin mutation. We screen for a panel of FDA-approved drugs using their iPSC-derived vascular endothelial cells. We understood the mechanism behind it, which is going after the KLF2, and then the lovastatin can activate it, and then we give the lovastatin back to the same patient. And so in summary, I think there will be a paradigm shift in the future using one example of this for quote-unquote precision medicine, and also for drug discovery that involves these patient-specific iPS cells to better understand the molecular mechanisms of diseases. These iPS cells can be differentiated into any cell types in the body, and then we can use then clinical genomics as well as a whole bunch of multi-omics sequencing that allows us to understand how different tissues in our body respond to drugs. We can then use these AI machine learning for molecular docking, for molecular dynamics simulation, and also in silico ADMET prediction. And then this will give us the drug targets that are much more precise, and then we can go back to test it on the patients themselves. So completing this loop of clinical trials in the dish. And as I mentioned, this is something that the FDA is very interested in. And you will see many, many, many examples of this from companies in terms of using this platform for their own in-house drug discovery. So this concludes my talk. I just want to acknowledge my postdocs, instructors, their funding support, and also some of the former trainees, my collaborators. And thank you very much for your attention. I'll be happy to take any questions.